Hi, welcome. I'm Dick Deming. I'm Medical Director of Mercy One Cancer Center, and I'm the founder of Above and Beyond Cancer. Welcome to our weekly cancer education series. It's brought to you in part by a grant from the Rosalie and Sherry Exline Ziegler Fund. And this evening, we're going to talk about hospice and hospice home care. And my guest tonight is my friend, Trey Wade. Welcome, Trey.
Thank you for having me. Glad to
So
be here.
Trey is an Iowa boy, grew up on the east coast of Iowa,
Betcha.
Sabula,
Sabula, you got it.
Sabula, and Trey was telling me that it's the only island city
Yeah,
that we have in Iowa.
very tiny. Graduating class of 28. So,
Okay, what was your claim to fame in high school?
I think my claim to fame in high school was being the one who caused the most trouble. I think
Okay.
actually, but there's not much to do in a town of 400.
Well, it's good to be known for something.
Absolutely,
Yeah.
absolutely.
And then Trey went to the University of Northern Iowa, and then got a master's in counseling from the University of Iowa, and a master's in health administration from DMU. And Trey is the president and CEO of EveryStep, and that is care and support services. And we'll talk a little bit about the evolution of EveryStep. For those of you in the audience that have been involved with hospice, you might have known of Hospice of Central Iowa, and that's one of the core services of EveryStep.
It is. Long history there.
So before we get into talking about hospice and then talking about EveryStep, tell us a little bit about your career. How do you go from growing up in a small high school to being president and CEO of the organization in healthcare?
Well, I knew I was going to be in a helping profession. So that led me to, a psychology degree, a counseling degree. And then as I moved into looking for a career, I knew that I wanted to work for a nonprofit. I wanted to be part of a team that was going to help and make a difference, a really mission-driven organization. That led me to a brief stop at Charles Urban Johnston.
Mm-hmm.
But then I had an opportunity to join Hospice, what was then Hospice of Central Iowa, in a team director position. And that was 18 years ago. So I had a little 1-year gap outside of grad school, and I've been with hospice ever since. It's really been a passion of mine.
Wow. And so for those listening that have children, and I just got a text today from someone who has a high school student who wants to get into counseling as a career. Tell us a bit about the pathway that you took, and how does someone who's interested in the healing arts and medical care, but in particular counseling, the path you took, and maybe some words of wisdom for how that path traverses.
Absolutely. I guess first and foremost, I'd say anyone looking to do that as a career, there's just a huge shortage. And so there's a lot of opportunity. If you're looking at my daughter's actually, you and I follow in my footsteps right now,
Okay.
looking to go into counseling. I think the nice thing about counseling as an undergrad, you can really have a wide variety of majors. You can go into social work, you can go into human services, you can go into psychology. I would say for people who want to take that as a career track and actually get into counseling and therapy, what they have to be committed to is knowing you're going to go for a graduate degree at a minimum, master's degree and perhaps even a PhD level degree. And that, you're really going to have a willingness to work with a number of different populations, really try to figure out what track you want to take. If you want to do children's, adolescent, for me, grief and loss was something I was passionate about from a very young age, and due to some of the family dynamics I'd had. And so I knew I wanted to, go into that type of counseling. And I think once you know that, there's just a great variety of programs, both within the state of Iowa and externally, that you can start down a career path. Therapy, therapists are in a huge demand right now. We just don't have enough.
Yes, definitely not enough. So you mentioned that initially you definitely had an interest in grief and loss. I've come to realize that probably my path to cancer was influenced by the fact my mom was diagnosed with incurable cancer when I was in high school. Mm-hmm. And I don't think I ever really thought, I'm going to be a cancer doctor because mom had cancer, but it's hard not to look back on my path and realize that her hand was probably on my back at crucial forks in the road.
Yeah.
You want to share a little bit about your?
Yeah, absolutely. Kind of similar. My both sides of my family, my grandparents died very young, so I didn't really get a chance to know them, and we weren't extremely close to my extended family. So and part of that, what I think was the chasm that started when my parents parents died. And so from there, it was always a little bit close to my heart, a little bit fascinating to me that we didn't have a lot of extended family we were close to, and that it really kind of all started with the dynamics around the death of my grandparents. And so, seeing how my parents adapted to that, seeing how the type of people they grew into after that really kind of led me to, have a curiosity around how people deal with grief and how they're going to move past. And then once you start working in the field and you see, more traumatic grief and how people are going to have to try to navigate their lives after a car accident or, an overdose or a homicide or a suicide. I mean, to me, that really, seemed to be a calling that I wanted to gravitate toward as I looked at my long-term career path.
And when you look at grief, I mean, people initially think, oh, it means getting over someone's death. But there's like in the world of cancer or any sort of trauma, an automobile accident, there's sort of this anticipatory grief. Also, there's the loss of things other than your life. It's the loss of your way of life, your income, your career.
Absolutely.
You're making changes. Or in the world of cancer, someone living with incurable cancer, there's also the anticipatory grief. So this the mental health component, counseling, that we all can benefit from as we're facing the demands of a serious illness.
Yeah, incredibly well said. I mean, the strain that it puts on an individual, a family, I mean, certainly the patient that's going through it, they're all very unique experiences, all very different, and all need different types of support to really navigate through it. And to me, that's part of, what's so special about that counseling therapy background. And frankly, with hospice care, which is that rare service that looks beyond the patient and says, we really need to create something and put it around the whole family unit to try to support them through this journey.
Yes. And even as we're talking about counseling, I mean, I think of hospice primarily as all of the counseling, not only of the patient, but of the family. But obviously, there's lots of hands-on physical care that goes with it, but is with this really a philosophical perspective of helping the patients and the family through a difficult time.
Absolutely. Yeah. I mean, I think with hospice care, it's really something that's designed to, a lot of people think it's giving up. And I would say it's the opposite. And I'm sure your experience has been the same, that, it's really about helping people thrive in the place that they are, building that team around them. And yeah, there's, most people gravitate toward the physical side of it. The nurses that are coming in, our palliative care doctor who can help with symptoms. But just as importantly, certainly within our hospice program and our philosophy is the psychosocial support, the spiritual support afterwards with our grief and loss programs through Amanda the Panda and our bereavement counselors. It's a very holistic type of service. And then you throw on top of it that it also was built around a system where it provides you with relief on pain for some of the medications you might be on, allows you to bring durable medical equipment into the home. I always say it's that rare win-win because most insurances have it because it is a lower cost providing care in their home than what you normally see in the hospital. And yet, families and patients just almost 100% of the time.
You touched on many of the aspects that people are going through. There's the physical, psychosocial, emotional, financial, spiritual. But I think the primary is the philosophical, this understanding that we can have joy in our lives in the midst of turmoil or even in the midst of a disease that will ultimately take one's life. Also, it's not about withdrawing services. It's about changing the focus.
Absolutely.
I had the conversation today with a family, and actually the conversation with another doctor who's been doing chemotherapy, and it's clear to everyone that more chemotherapy is going to be counterproductive. And philosophically, it's not that we're going to stop doing treatment. We're going to do a lot of treatment, but it's going to be different treatment.
Yep.
And so even philosophically, understanding we're not withdrawing services, we're bringing on a lot more services that are intended to improve your quality of life.
Yeah, I think that's a huge barrier. We don't get a lot of negative feedback majority of the time we get negative feedback, it's I wish we would have gotten hospice involved sooner, you know? And so I think that's one of those barriers is people really, that word is scary and it feels like we're giving up and it feels like, okay, now something is very imminent. And if that's one thing I would want people to take away is no, that's not the case. You know, we have people on service for half a year. You know, we have some people that graduate from service because they no longer qualify because they are doing so well.
Yeah. I mean, I have one of the most inspiring patients I had, Jenny. Jenny was cured of endometrial cancer and then in her 80s developed lung cancer and enrolled in hospice home care and then was enrolled in hospice. Jenny would come to this room every Wednesday night to the lecture. Every Wednesday night when the lecture was over, would go upstairs and do spin class. Went into hospice, got better, came out of hospice, came to spin class with oxygen after having been in hospice. Yeah, it's just amazing. So let's talk a bit about pragmatics. What is hospice? And, you know, what's the difference between hospice home care and hospice facility care?
Yeah, great question. Right. So hospice is really a bundle of services that are built around people that have a life-limiting illness. They have what a doctor would certify as to be a terminal illness, and they're no longer pursuing curative.
And we would talk about in terminal, correct me if I'm wrong, is defined as 6 months or less. That if the disease were to run its normal course, we would predict that the length of survival would be 6 months or less.
Spot on.
Yeah.
Yeah.
And even that term, just that word terminal, is sort of, I like to say, living with incurable cancer. And nowadays, many patients with incurable cancer with immunotherapy and targeted therapy, it's not uncommon to live a decade with incurable cancer. Now, you're not ready for hospice at that point, but at the point that the doctor would say that we're at a point where we would predict that the survival is 6 months or less, then that's an appropriate time to bring in hospice services.
Yep, absolutely. And I think you nailed it well when you said under the normal progression of the disease, which as a physician, I'm sure you would say, well, what is that? I mean, you know, people are just, each people is on their own individual journey, right? So yeah, and it's it's a group of services. It includes nurses, and in-home hospice would be nurses coming to your home, or hospice aides coming to your home if you need some help with bathing, housekeeping, some, being able to maintain that daily living. And then there's the psychosocial support, our social workers, our spiritual care counselors who are going to come in and really try to support, again, not only the patient, but the family, and when that's possible in the home and when people want that in the home, that's what we always want to strive for, whether that's home or residence and assisted living center, nursing facility, bringing that team in and keeping them independent where they want to be. When that's not possible due to either, they have a caregiver need, or maybe there's something going on with symptoms where we just can't seem to get things under control. People are uncomfortable physically, spiritually, mentally. Then we would look at that Kavanaugh house placement or hospice house placement, where we have a little bit more ability on a 24/7 basis to provide, a little bit higher level of care where you can really keep eyes on them and give our palliative care physician more opportunities to see them in person.
And here in Des Moines, Iowa, the Kavanaugh House was the first freestanding hospice facility.
It was.
And when I came to Iowa 34 years ago, I actually was a volunteer on the board of directors for Hospice of Central Iowa. It was the very first not-for-profit board that I ever sat on. And during my time there, we built the hospice facility. Remind me what year that was completed.
So it would be
91.
Yeah, it would be. We just had our 25th anniversary 4 years ago, I think. So yeah.
Okay. Yeah. Exciting.
Almost 30 years ago.
And as the services that you provide have grown, your name has changed from Hospice of Central Iowa to EveryStep. Tell us a bit about that evolution. And now, besides hospice home care and hospice facility care at the Kavanaugh House in Des Moines, what is encompassed by your organization, EveryStep?
Yeah, I would love to. So, we're a freestanding nonprofit. And what that means is anything that we can do to have positive margins, we put right back into the community, right back into the business. From that standpoint, we wanted to best utilize those limited dollars we get. Healthcare, human service, there's not huge margins. And so about 12 years ago, we started looking for a partner, another nonprofit that had a like mission, so that we could drive less cost to people like me who work in administration and are, less cost to HR, billing, and more cost to the bedside, to our patients, our clients, our families. So we decided to partner with Visiting Nurse Services, and they have over 30 programs that mostly are geared toward children, pregnant moms, young adults. And while on the surface, maybe that didn't make a ton of sense, hospice serves all ages, but is mostly a geriatric population. And Visiting Nurse Services has these wonderful programs that serve, at-risk moms, people that are going through that first pregnancy. That commonality was we're helping people at just a very, vulnerable time in their life, whether you're a 100-year-old veteran at end of life or a, 15-year-old first-time mom who's, not in the best living environment and needs a lot of support. And so we did decide to come together. From there, we had a lot of other nonprofits that reached out and said, what you're doing is the path to thriving. And so we had Amanda the Panda joined our family of services. We've had a lot
and that's a grief and bereavement program.
Yep. Thank you. Our Amanda the Panda Grief and Loss Services. We have a grief and loss center here in Des Moines. And then some other nonprofits outside of the Des Moines area. Over time, we just realized, we have over 30 programs. We're serving over 60,000 Iowans a year. We have a wonderful story to tell. It's just hard to tell it under so many names. And considering we're helping kiddos before they're born, and we're helping families after the death, and we have all these programs in between, we thought, EveryStep was a fitting name for the services we offer.
And besides the Kavanaugh House, a freestanding hospice in Des Moines, Iowa, does your umbrella of EveryStep include other hospices in the state of Iowa?
It does. So we have 9 locations outside Des Moines. So pretty much we cover all 47 counties south of 80 with our hospice program. And so we have offices in Mount Pleasant, Centerville, Knoxville, Mount Ayr, all led by local leaders, all employing local people, so that those communities and those surrounding communities can get hospice services.
So I think the audience there is seeing the map. So south of I-80 is your territory. How many of those have freestanding hospices that are separate and distinct from a hospital?
Each of them, no, we are not affiliated with a hospital in any of those locations.
Gotcha. Some communities, for example, smaller hospitals might have a floor or a couple of rooms that they call hospice, but they're really just hospital rooms, but they do hospice service within a hospital that has some extra rooms.
Yep. And we have many of those contracts with our partnering hospitals. So I might have misunderstood your question, but we look to partner locally. We never want to replace, we would never look to build a hospice house, for example, when the hospital is saying, hey, we're here as a community resource. But each one of those is independent. Many of the programs that we have opened are due to hospitals that have reached out and said, we're going to focus on services that happen inside our walls. We're not going to do hospice and home care anymore. We need a good community partner. Would you look at moving into our community and just kind of taking over? And we've done that in a number of communities.
Gotcha. So your umbrella of services include what we would traditionally call home care. That's not hospice. It's for somebody had back surgery and is at home, but needs some care at home as they're rehabilitating. And do you, in some communities, probably the staff that does home care unrelated to end of life and the home care that happens in hospice are done by the same providers, or
occasionally with CNA services to go in and help with those activities of daily living. We actually originally thought that we would, be able to leverage in these smaller communities a nurse to do both. But, it's very specialized care, both home care, which is more geared toward rehab, getting the person better, getting them up and, moving along.
Right. Sometimes a kick in the butt, a can of suck it up, as opposed to a goal of a peaceful death.
Comfort, yeah, and making sure that people are, getting what they want out of life, no matter how long that life is going to last. And so, we've really found people either have a passion for one or the other and a skill set for one or the other. So we don't have a ton of crossover with our clinical staff.
Okay.
Yeah.
Let's talk a little bit more about what would happen. Let's say an individual patient of mine who has been experiencing going through the cancer journey for 3 years with what we've known as incurable cancer. It's gone from some chemotherapy and radiation therapy. Cancer progresses, more chemotherapy, and ultimately it's clear that further anti-cancer treatment is not going to improve the situation. And we want to have that initial conversation about bringing hospice services on board. As you've already noted, that word can be very terrifying and off-putting and feel like defeat. So part of it is how do I, as a doctor, talk about it and talk about not withdrawing services, but bringing on additional services. What was the first meeting like for who in your staff would be present at that first meeting when the family is still trying to vet what is it? Do we really want to sign up for it or not? Who goes out to the home and meets with the family?
So we have admission staff that would go out. It's usually an RN. Sometimes it's our physician, depending on the dynamics around the diagnosis and what the patient's going through. But a majority of the time, it's going to be one of our RN staff who is going to go out, talk a little bit about what we do. That initial admission call, I always say make that call, because we can easily go out, explain what the services are, evaluate if you qualify. You have to qualify under the benefit. And then, if it's not something the family and the patient's interested in, that's okay too. Then we're here. We're a phone call away. You've had that connection. So I say, when in doubt, just give us a call. But our staff also do a good job of trying to alleviate some of those fears of this. This doesn't mean that tomorrow's the end. This doesn't mean that you're giving up hope. It's really actually on the contrary. Like, how can we put the services around you so you can, still get out to your granddaughter's ball game, so you can still be comfortable in your home, so you don't have to go into a higher level of care, a nursing facility, to really build something around you as a team. I always cite, I think it was a Duke study a few years ago that found that if you take, I think it was a cancer patient who needed hospice care and didn't get it. They were at that point in their treatment. And then the one that did get hospice care, the one with hospice care actually lived on average about 4 months longer. And that makes sense when you think of the services they're getting. But I do think that's, it's one of those misperceptions, is that people who go into hospice are going to have a shorter lifespan. It's not the case.
Right.
Yeah.
It's talking still about hospice home care. Need to be honest with patients. It's not like you come in and you're 24/7, got a nurse there, you got a doctor coming, you got the physical therapist, you got the pharmacist. So there's a limit to the amount of personnel and the services. And I always explain that hospice helps the family care for the patient, but primarily with hospice home care, it's still the family that is the primary service provider, with the assistance of the wonderful staff from hospice.
Yep, very, very great point. And every once in a while that happens, right? As we come in and it's what can we do for you? Well, we need someone here with mom 24/7, and that isn't the type of service that hospice offers. And as a matter of fact, that's where it gets to, is a higher level of care needed? Is Kavanaugh House an option? When you get to the point where people are saying, I don't have the ability to either care for myself and I live alone, or a loved one says, this has gotten to be too much. It's really built around how do we support you and your caregivers so that you can, stay comfortable in the home, stay independent as long as you want to and as long as you can. But very well said. It's not a 24/7 service. It's not going to be something where you'll have people in your home for, hours a day, every day. It is an individualized care plan. There are times if you're having symptoms, we may visit every day. We may send out a nurse every day. We may send a different part of the team out every day, but it's certainly not built to be a service where we're, setting
Right.
up shop in your house.
Yeah. And at the beginning, it's great to get people involved before they need a lot of services, and also tell them, you're still the boss, you're in control. If you don't need these services, you're working with them. They're not going to come out and force you to take a bath.
Right. Oh,
and
absolutely.
they get to know you before you need the services, know what your likes and dislikes are philosophically and emotionally and spiritually, where you're coming from, and can help you. What are the various services that you can provide within the home, the different types of professionals that you have that come into the home and help patients in hospice home care?
Yeah, great question. So the most frequent person that's probably going to visit would either be the nurse who's going to go out there and clinically be, I always say they're A, wonderful clinicians and experts in their field, but B, also the eyes for the physician. So they're often going out, anywhere from 1 to, 3 times a week, possibly 4, 5, 6, 7, depending on what's going on for a short period of time. If the patient's having some symptom issues and they're going to lay eyes on it, they're going to be talking to our physician or the attending physician that we work with, and really trying to help in that way. CNAs who are going to go in and help with activities of daily living, bathing,
And a
housework.
CNA is a certified nurse assistant.
Yep.
For those who might not know the initials.
You got it. Yep. Psychosocial support. So our social worker that's going to come in and do a number of things around where the patient's at as far as their psychosocial, mental, and emotional needs, but also work with the family. They're also going to help coordinate any kind of services around, if someone needs to apply for Medicaid, needs help with their insurance coverage, needs help with some of the paperwork side of things. Our social workers are wizards at that. Then we do have spiritual care support. And again, any of these services, we want them to come into the home and to help. Any of these services other than nursing, which is required by our regs, you could say we don't really want that service. It's not something we're interested in. But spiritual care support to come in and really help people on their journey from that perspective. We do have a full-time doc. Not all hospices do, but we're lucky to have Dr. Mosier. So if something unique is going on in the home with the symptoms, he may come in and do a visit with the family just to see how he can help.
And speaking of the doctors, you talked about your physician that's an employee of EveryStep that's able to come into the house, but then you also talked about the attending physician. So patients also have the option of continuing with their own physicians that manage the care, and you work with
Absolutely.
the physicians so they don't have to transition to a different doctor if they don't want. They can continue to have their own doctor manage their care.
Absolutely. And that actually happens the majority of the time. Each and every doc who trust us with the patient, we know they have that existing relationship, that existing history. And so chances are we're going to work in conjunction with that attending physician, unless for some reason the attending physician says, hey, at this point in the journey, I actually prefer if you would step in and help out, or vice versa, the patient or family say that.
Yeah. And then distinguish, or let's say a patient and family are committed to the hospice home care, and it may last for months. We mentioned that a doctor has to say that the expected life expectancy is 6 months or less, but you don't kick somebody out of hospice when they surpass that 6-month point. They remain enrolled. Sometimes patients do get better and disenroll from hospice, but sometimes patients do survive better, and certainly sometimes you see patients get better when you stop giving chemotherapy that wasn't working. They actually get better. Let's talk about the transition as patients continue their expected journey with an incurable disease and start getting weaker and more bedbound, and the families there able to support. How do the services change? And then, another really wonderful thing is when you've been with the family and then at the time of death, and how you help patients, families through that process at the time of death.
You bet. So, I'd say every care plan, we really work hard to individualize, not only patient to patient, but also where they're at in their journey. So as you start to see changes, and that's really what you look at once someone gets on hospice, is are you seeing change, however slow, seeing change, they were getting up and around, and then now they're using a walker, and now next week they're not getting up at all. Those are the types of changes that we say even though it's been 6 months, this person still qualifies and should be in hospice care. And really, so then we adjust there. We'll increase the frequencies of the visits around our nurses if there's symptoms going on, our aides if the activities of daily living slow down and they need more support in the home. And then even those psychosocial and spiritual visits may increase because, as you know, as things are getting closer, there's going to be, emotions and intensity around that for both the patient and the family. And so we want to make sure we support them. One of the things that I think is wonderful about hospice is when that time comes and when a patient passes away, we are 24/7. And so you pick up the phone, and frankly, that's not just at the time of death. Obviously, you can pick up the phone at any point, but including when the patient does pass away or something's changing, and you can have someone there. The nurse is going to be on their way in a moment. They're going to be there to be able to educate you as the loved one and the caregiver on, hey, this is what's happening, this is what's going on, and to be there for the patient. And I think that can be really comforting.
Super comforting. And family may be doing everything exactly right, but they don't know they're doing things right. And, they got the medicine. Do I give more medicine or not medicine? Am I going to give too much medicine? And they just so many questions because most families haven't been through this before.
Yep.
And are afraid that they're going to do something that's going to make the situation worse.
Yeah.
And then you mentioned at the time of death also, so comforting to just call someone who can then be there and take care of all the logistics. You don't have to, oh gosh, do I call 911? Do I call the hospital? Do I call the coroner? Do I call the funeral home? Who do I call? You guys just come in. Family can tend to themselves and support one another, and you support that, but you also take care of the logistics, the details that have to happen at that point.
Allows the family to be family, and then we can go in and make sure that things are happening with calls, like you said, whether it needs to go to a funeral home or a hospital, and coordinating that and staying as long as we need to coordinate that. And I think. Just being there, you touched on a great point, being there to reassure the family. Well, the big one we get in America, and certainly within Iowa, is, as patients are changing and slowing down, they, as they don't eat, they don't drink near as much. They don't have a desire to, they don't want to, so it's those type of things that, caregivers are reaching out and saying, geez, he won't eat. I'm trying to feed, and it's just that education, reassurance on you're doing the right thing. You're providing great care. Keep doing what you're doing, and we're here. We're a phone call away.
And then maybe talk a bit about what happens in the Kavanaugh house. So a patient either has needs that can't be met at home. What are some of those? Like uncontrolled pain that needs perhaps IV pain medication or injections, something more than just a pill, or other physical needs, or they don't really have a family that is able. Sometimes it's physical work when you're caring for someone who can't get out of bed and you're trying to help keep things clean, roll the patient, move them or assist them. It can be very difficult for an elderly caregiver to actually physically do all of that, and then to even know that they're doing it correctly. So there are some times where being in a hospice facility actually provides greater relief and comfort for the family as much as for the patient.
Absolutely. Yeah. I mean, I think the best way to put it is if for whatever reason that patient family say this house isn't the best place for our loved one anymore, whether it's because we're having trouble caring for him or her, or, sometimes it's as simple as, I don't want this to be the legacy. I don't want to, especially with a younger patient, I don't want to die in my home and have my kids know that, so I mean, it's really that personalized journey of, for whatever reason, it can be physical. If we have changed the medications, we've altered them, we've tried to get them on a regime and it's just not getting their symptoms under control. But it also can be spiritual. It can be the need of a caregiver. It's always nice just to have that inpatient unit as somewhere to transition to when that level of care just can't be met at home. Before that gets to the breaking point and the family just is at their wit's end and saying, I don't know what I'm supposed to do here. And sometimes people come into the Kavanaugh for a few days, and we get things under control and they say, yeah, I want to get back home, and they're comfortable, whether that's physical, spiritually, or mentally. And then other times, patients might come to Kavanaugh and then they end up staying and for the rest of their journey.
And sometimes they might come for a respite where the family just like they have life going on as well and may need to support a family member who's playing in the state basketball tournament and the family wants to go and somebody needs to be. And so, well, let's have mom be in hospice for just a couple of days while we do something that really the family needs to do and allows them to feel comfortable that their loved one's being cared for, and then come back home after a respite visit.
Well said. Yeah, that's exactly. It's one of those great things about the benefit that if you're getting hospice care in your home and you even just, I need a break, I'm not going anywhere, I just need a break. Then, we have options not only at the Kavanaugh House, but in those other offices. That's where we have our great partnerships with most of our hospitals of, hey, we need to do a respite stay for, 2, 3, 4, 5 days. And you coordinate that care so you can get that relief.
So if someone is being cared for in the hospice facility, clearly there is a nurse there 24/7 and other staff. What's the family's role of caring for the patient once they're in a hospice facility?
Great question. Yeah. I mean, it's certainly less intense because we do expect to go in now and we're providing those daily supports, that 24/7 care, that getting them up to the bathroom and getting them back into bed. If they need a bath or a shower, then we're taking on more of that role as the primary caregiver. But the house is really built to welcome families, and you mentioned you were there when it was built. We just did a capital campaign and renovation 2 years ago. And that was one of our big focus areas, is making sure we had space because we know family are going to want to come and they're going to want to stay. I would say the difference between Kavanaugh at home is you're there just as a family member.
Yeah, you're providing the family love and support, but you're not required to do the physical and medical and hygiene type of work that has to be done.
Yep. And, meals, you name it. Yeah. Then our staff are stepping.
But families are welcome to be there 24/7.
Absolutely.
There's beds for them to sleep in. And
yeah. So again, when we did that redesign, we wanted to make sure we had fold out couches so people could sleep, because that was one of the things we'd heard by feedback is, sleeping in that little recliner isn't great. We implemented a family shower area. So people, if they're going to stay, they could shower. They have access where they can order food from our kitchen. It's really about, again, that holistic care that we're providing of, there's such a focus on that patient, as there should be, but there are other people involved in this journey. How can we best support them through it?
The hospice of Central, the EveryStep used to be Hospice Central Iowa, and the Kavanaugh House has a great reputation. Tell us a bit about the name Kavanaugh House.
Yeah, so Sister Eve Kavanaugh, as I'm sure you knew well. Sister Eve was the founder of Hospice of Central Iowa. Sister Eve's still alive today. She actually came back a few years ago when we had that 25th anniversary celebration. She is wonderful. She is a dynamo. She is just this tiny little ball of energy. And, she still tells the story so wonderfully about how she had, went to her church, said she wanted to start a hospice program, had gotten some pushback because at the time, these are her words, not mine, but at the time, that's not something they thought a woman could do. And to hear her tell the story about how she just put her foot down and started out, she started out as a volunteer service, going out and on her bike and providing care to people in Des Moines who are at end of life. And then certainly, as hospice became more established as a legitimate course of care, played a big role in starting our organization. And I still get an occasional email from her, or I'll still reach out to her occasionally. She's in New York now. And, last time I talked to her, was doing wonderfully.
Yeah, it was wonderful to see her at the event. So let's talk a little bit, tell us more about some of the other services that is under the umbrella of EveryStep. So you mentioned the visiting nurses that go out for other situations besides end-of-life care. And you mentioned maternity and early child. How do those referrals come to EveryStep.
Yeah.
As a cancer doctor, I know how I can bring you guys on board for my patients. How do some of those other services, how do you get engaged?
We continue to have great partnerships, versus a cancer doc. It might be an OBGYN who's seeing a mom and they know they need some support inside the home. Schools might call us. Certainly word of mouth. We help a large population of the refugee and immigrant population, and those communities are very close knit. And so when we have the good fortune to help a mom to be in one of those communities, we laugh that we'll show up to talk to her and see how she's doing. And there's 3 other people in the room waiting, saying, how do they get services? There's services that are really geared toward making sure the end goal is to have a healthy pregnancy. And we know statistically that our Black and brown population has a much lower rate of healthy pregnancies and births and a higher rate of death during childbirth. So it's a big focus of ours, is helping the Black and brown population. And then making sure that once that baby's born, that family unit and that kiddo have the supports they need within the home to make sure that they're hitting those developmental markers appropriately and they're having success there, with the end goal being, age 5, they're off and running and ready to hit the ground in kindergarten.
So when you look specifically at the prenatal services and the services right after birth, is that reimbursed by Medicaid, or what is the model, the insurance model that allows you to receive appropriate compensation for doing the services?
Yeah, it's a puzzle piece. A lot of it is grants. So we are the holder of the Healthy Start grant here in the Des Moines area. So that's a federal grant that provides services. It's just like it sounds, to make sure that kiddos, as they're born, are getting off to a healthy start and making sure they're hitting the milestones as appropriate. The Nurse Family Partnership Program that we have is wonderfully supported by United Way and Early Childhood Iowa. We have some grants that come from the state through the DHS, or the holder of the Title 10 and the Title 5 grants here within the state in the Des Moines area in this region. And those are grants that support some of the maternal child health programs and some of the services we offer. And then we rely heavily on, both within our hospice program and these programs, our own foundation, who is responsible to raise money and make sure that we can, make these services available. Almost all our services across all 30 of our programs come at little to no cost to the recipient of the services. But it's definitely a puzzle on the back end of, is it a grant? Can you bill Medicare? Can you bill Medicaid? Do we need to raise dollars for it? But that's energizing, man. That's running a nonprofit.
Yes. Yeah. What services does EveryStep do that I wouldn't have a clue that they do, that I'd be surprised about?
Are you familiar with our Stork's Nest program?
Your Stork's Nest?
Yeah.
No.
Okay. No. So Stork's Nest is a program that we have that moms to be at a certain percent of the poverty level, they can participate in the Stork's Nest. They get points for healthy behaviors. So, going to those well-child doctor checks, maintaining employment, smoking cessation, those things that we would want to make sure the steps they're taking to have a healthy pregnancy. And then we have a small Stork's Nest store where they can utilize those points and come in and use it to buy formula and diapers and car seats and cribs and some of those things that they need to make sure that that new kiddo has what they need to stay safe in the home. Okay. So that's one of our programs.
Okay. So you're not into restoring the bird population?
No, definitely not hit that yet.
Nest. Okay.
Yeah.
You're right. I didn't know about that.
Yeah. It's funny, whenever we, each week I get the good opportunity to meet new staff members, and we have, 400 employees. So there's, constantly new people coming through the door, and it's a very rare week as I take them out on a little tour to our locations just in Des Moines and get to know them a little bit, that people that are joining our team aren't like, I had no idea you did this stuff. It's a very diverse organization that does a lot of really wonderful, unique things.
So let's open it up to some questions and answers. Trey will supply the answers. And so we'll keep an eye on, if you're watching us virtually from home, just put the questions into the comment section. And we've got some questions here from our live studio audience.
So Trey, staffing shortages, is that a problem now? And are you concerned about it looking into the future?
Absolutely. Yeah. We've had good success. I'd like to think we're a good employer and that people enjoy working for us. So we minimize our turnover, but in those clinical positions that all of healthcare is struggling with, it's really put us in a precarious position this past year due to the nursing shortage. You especially feel that at a Kavanaugh House. It's a 24/7 facility. And what we're really experiencing is the expectancy for nurses and clinical staff. They don't want to, not as many anyway, want to work weekends, want to jump into an evening position or an overnight. So those have been incredibly challenging and expensive. The cost of care has certainly risen dramatically.
So at my hospital, and I would say probably every hospital in the country, has had to rely on traveling nurses. Have you had to hire traveling nurses to fill some shifts?
Yeah, we limit that to the house. So many of our other clinical positions, whether it's on that maternal child health or the hospice and home care side, you're independent going into these homes. You're an island of one. So if we have to use contracted nurses in any way, then we want to make sure they're in the Kavanaugh House. That way they can be paired up with one of our experienced nurses to, for guidance questions. But we have at times certainly hit that point where we've had to look at using those in the Kavanaugh House.
Yeah. What are the other positions that you're finding difficult filling in the current environment?
I would say the hardest position has been clinical leadership. So our both Kavanaugh House, who recently had a resignation of their team director, wonderful leader who was with us a very long time, and then our home hospice program in Des Moines. Finding director level individuals to lead those teams has been really, really difficult over the past 3 or 4 years. And I think that's, you have the shortage of clinicians, period. And then the shortage of clinicians that want to, get into that kind of, stressful position where you're leading others and you're dealing with the shortages. So I'd say that's probably been the biggest area where we really, have been looking to have a good leader to support our teams.
Okay. Yeah. Other questions?
Yes. If someone have life insurance, which is for long-term care, and they're not in a nursing home and they go into hospice, is that something that would kick in and pay for the hospice care?
It's a great question. Unfortunately, it wouldn't. I will say that most insurance programs have a hospice benefit. And so we're very fortunate there. We don't see a ton of people who have, whether you have Medicaid, private insurance, or Medicare, there's not a ton of insurance plans that don't have some kind of hospice benefit. But as far as being at the Kavanaugh House and staying there for an extended period of time, most long-term insurances, great question, but unfortunately, no, they wouldn't cover that as a nursing facility. Good question.
So Gary has a question for us over here.
Awesome.
I remember growing up that there was no hospice or anything like that.
Yeah.
When did hospice really start? What was the organization, and when did the government really help in being able to support that? And then just as a second question, I think my neighbor's the fact that, one of the spouses, had, a stroke and was, kind of didn't last very long. Would there be anything that EveryStep would be able to help out in that?
Yep. Let me answer both those. So hospice is has a pretty recent history. Dame Cicely Saunders from England was really the leader of the hospice movement. It happened in the early 80s. And so it hasn't been around for very long. And much like we mentioned with Sister Eve, it started as a volunteer movement where people really were volunteering their time and their support for people who had had a terminal illness and had hit that point where maybe curative treatment wasn't an option anymore. And yet there just wasn't anything else there for them. And so it started out as really a volunteer movement within the medical community. And then you started to see the benefits from it, both for the patient, but honestly also for the payer sources, because offering services in your home is so much cheaper than someone being in an ICU or, you know, a hospital for days or weeks or months. And so I think around the mid 80s, Medicare was the first one to identify that it would be a benefit for them. And then other insurance companies followed suit. It's probably, I mean, you had to be on the front end of it here.
Yeah, so I came to Des Moines in 1989 and Hospice of Central Iowa. I don't know when it first became an entity, a 501c3, but I was on the board of directors probably 1999 came on. And at that point, there was no hospice facility in Des Moines, Iowa. So Hospice Central Iowa, a freestanding independent of Methodist Hospital or Mercy Hospital or Lutheran Hospital or Charter Hospital or all the different hospitals we had at that time, was the first organization to actually build and create a inpatient facility, but had for years had been doing out home care. And as we said, that was in the very early 90s that the first hospice facility. But even when you think how many decades that is, we now have only 3 hospice facilities here in Des Moines. So in addition to Kavanaugh House, which is EveryStep, formerly Hospice Central Iowa, Mercy has a hospice facility, which is in Johnston, and Unity Point has a hospice facility, Taylor House, which is in East Des Moines. So right now, those are the 3 inpatient hospice facilities. But as Trey said, most of the hospice care that happens is hospice home care. And there still is, though, a real big need for the inpatient facilities. Inpatient facilities are more expensive to care for. You've got round-the-clock staff as opposed to home care. And a lot of that is a bit dependent on the rules that are set by Medicare, Medicaid, independent insurers as to whether what's the situation in which they will pay for a patient to be in an inpatient hospice. If you've ever been in an inpatient hospice facility, they're wonderful. There is the quiet and peaceful and sacred space. So you can imagine if you are the family member of an elderly person who doesn't have a disease that's going to result in their death in 6 months and are living in a facility that isn't so nice, you go, can't we just move to hospice? I mean, at times I thought, like, I'll take a room in hospice, and it's just such a sacred space. But you can't afford, unfortunately, we can't afford as to have everyone live in a hospice facility for the last 3 years of their life. So to make it able to work, you have to set up these rules as to who is eligible to be in a hospice facility and have an insurance program pay for it. Yep. If you don't have insurance, you can still go to a hospice facility, but it would generate a $250 a day or maybe even more now.
Yeah, I think if you have the means, I mean, the nice thing with EveryStep, we are a nonprofit, we have a foundation, we don't turn away anyone for an inability to care. And so if somebody does come to us and they don't have insurance and they need our services and they hit our financial assistance guidelines, then our foundation picks up the tab for that. Most frequently where that hits is at the Kavanaugh House, because there's not an easy way to pay for that room and board side of things. And, so we do around $300,000 a year in charity care at the Kavanaugh House when people don't have the means to pay for it.
And it's wonderful. And just sort of explaining that if the insurer says, well, they're not really getting medical care, they're getting a place to sleep and a shelter and 3 meals a day, there are insurers say, well, that's not medical care. So in order for an insurance company to pay for somebody to be in a hospice facility, there's the expectation that they're receiving medical care that they can't receive elsewhere. And that's why it's paid for by health insurance, not paid for by the same types of payments that pay for nursing home services.
Well said. Yep. As far as your other question with the neighbor that had a stroke and had a fairly short stay before they passed on, we always encourage a call for a couple of reasons, even if we don't think that the patient is going to be with us for very long. Is one, we can bring in services to get around that patient and that family. But two, we want to serve people for as long as they can. But if, we literally receive calls where people are on our service for minutes. And the point of that is we believe in our mission, and part of our mission is our bereavement care services that go follow the family for a year afterwards. So if we can get that person admitted, even if they're really late within their journey and they die very shortly after admission, then that family, those caregivers get pulled into our bereavement program for the next year, where our bereavement counselors will reach out to them and see how they're doing and try to support them in that way.
Great. Do we have any questions from our online community? Okay. Well, we are at the end of our hour. And thank you so much, Trey, for being here and for explaining hospice, but even more broadly, all of the programs that are done through EveryStep.
Thanks for having me.
So thanks, everyone in the audience, for being here. If you know someone that would benefit by watching or listening to this program, this will go online and be available on demand at the Above and Beyond Cancer YouTube channel or the Mercy One Cancer Center website beginning tomorrow. Thanks for joining us, and please join us again next week. Thanks, everyone.